Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 63rd virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Common Golf Injuries and How to Maintain Your Game, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it too, so that they can view it once it is posted on the IBJI and NSYMCA websites as well. If you're on this webinar, my guess is that you're a golfer or you care about a golfer, and you're probably aware that shoulder, elbow, and knee injuries in the game of golf are quite common. The golf season in Chicagoland is way too short to have it dampened by injury. So if you're experiencing pain, it's important to seek treatment quickly to avoid a long-term setback. In fact, many common golf injuries can be prevented with proper technique and conditioning. Tonight, Illinois Bone and Joint Institute's Richard Nicolay III, MD, will discuss common orthopedic golf injuries and tell you how to protect your body, recognize early warning signs, and get you back in your game pain-free. Dr. Nicolay is a board-certified orthopedic surgeon with fellowship training in sports medicine and shoulder surgery. He specializes in the treatment of injuries to the large joints, including the shoulder, elbow, hip, and knee, and has expertise in sports-related injuries and shoulder replacements. Dr. Nicolay completed his orthopedic surgery residency training at Northwestern Memorial Hospital and trained in pediatrics at Ann and Robert H. Lurie Children's Hospital and trauma at John H. Stroger Cook County Hospital. While at Northwestern, he worked closely with the Chicago Blackhawks, volunteered as a physician for the Chicago Marathon, and trained under past and present head team physicians for the Chicago Bears, Bulls, and Cubs. At the completion of his 5-year residency, he was elected to serve as chief resident and was awarded the Brian Hardigan MD Memorial Award for demonstrating compassionate care, clinical excellence, and dedication to teaching. Dr. Nicolay then completed his fellowship at the Hospital for Special Surgery in New York City, the nation's #1 hospital for orthopedics, where he completed advanced training in sports medicine and shoulder surgery and served as a fellow team physician for the New York Rangers and New York Liberty. While in New York, Dr. Nicolay trained directly with the team physicians for the New York Yankees, Nets, Knicks, Mets, and Red Bulls, as well as Team USA basketball and swimming. Dr. Nicolay then traveled abroad to complete a mini fellowship in advanced shoulder replacement techniques, working with leaders of the European Society for Surgery of the Shoulder and Elbow in both Switzerland and France. He serves as a reviewer for the American Journal of Sports Medicine, Orthopedic Journal of Sports Medicine, Journal of Shoulder and Elbow Surgery, and Arthroscopy Journal. Plus, he was the co-recipient of the first place overall research poster award at the 2022 American Academy for Orthopedic Surgeons annual meeting. In his spare time, Dr. Nicolay enjoys spending time with his family, fishing, water sports, woodworking, drawing, and photography. I don't think he ever sleeps. When treating his patients, he follows the golden rule, which means that Dr. Nicolay treats his patients the way he would like to be treated, or the way he'd like his family members to be treated. He says that he finds it incredibly rewarding to work together with his patients to develop a treatment plan that ultimately relieves their symptoms and relieves their pain so that they can get back to what they love to do. He says it's the best part of his job. During Dr. Nicolay's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the questions section on your screen, and I will receive them and relay them to Dr. Nicolay immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Nicolay via one of the options that will be listed on the slide shown during the Q&A portion of the program at the end of his presentation. One last thing before I return the evening over to Dr. Nicolay, please mark your calendar for our next IBJI and YMCA Education Series program on Tuesday, June 24th at 7 p.m. Dr. Peter Hefner will discuss common hand problems and treatment options. Thank you again for joining us tonight, and thank you to Dr. Richard Nicolay for your time and effort in putting together this program to educate us about common golf injuries and how to maintain your game. Dr. Nicolay, please take it from here.
Well, thanks, Karen. I really appreciate the introduction. Let me pull up my presentation here and we'll get started here. Thanks again for the introduction. I'm excited to be here and give this talk today. So we'll talk about common golf injuries of the hip, knee, and the shoulder. We'll talk about the most common pain generators for each location. We'll go into some anatomy. I have some diagrams and some videos that help understand what each of these joints look like below the skin, which can be helpful when trying to determine where your symptoms are coming from. We'll talk about the symptoms that each of these conditions generate so that we know what to look out for when you're out on the golf course. And we'll talk about treatment options for each. And obviously, whenever we're evaluating patients for pain and trying to treat their joint symptoms, we're starting with conservative treatment first. Oftentimes that involves the simple things, rest, ice, anti-inflammatory medications, and we'll go through those in detail. And only when things escalate and fail to respond to conservative treatment are we talking about surgical intervention, because most of our sports surgeries are elective. So we'll also talk about surgical intervention throughout this talk, but hopefully we can avoid that by treating your symptoms conservatively. So we'll use Rory's master celebration here as kind of a guide for our treatment. Or our talk today. I've given a lot of presentations before, and I've never had to give photo credit to Ken Griffey Jr., so it's a pretty cool moment there, and a pretty awesome photograph. So we'll go through injuries, and we'll start with injuries of the knee, and then after that, we'll move on to injuries of the hip, and then finally, we'll finish up with injuries of the shoulder, and we'll talk about the anatomy, symptoms, and treatment options for each. In general, when we're talking about joint pain, we divide symptoms into two main groups. So we have acute symptoms and then we have chronic symptoms. Acute injuries can be generated from muscle strains. That tends to be the least severe. Those tend to get better quickly on their own. Tendon injuries, which include partial tears, and you can have full thickness tendon tears as well. Ligament sprains, injuries to the meniscus for the knee, and then the labrum for the shoulder and the hip. And then fractures on the more severe side. Thankfully, those don't happen very often on the golf course. Typically, they involve a golf cart when they do. For chronic type injuries, patients will experience tendinitis. Arthritis can generate chronic symptoms. Stress fractures are more on the severe side. That comes from a sudden change in activity. And those are some of the more concerning ones we have to identify. And each joint has its own nuance with different structures that can generate pain. So here's a diagram of the knee. Pull up the video here. And hopefully it's going to work. Okay, there we go. This is a nice video from an anatomy website that helps really understand how the knee moves. So the knee is a hinge joint. What you're seeing up top is the femur, and then down below is the tibia. And in between are the important structures of the knee. And as you can see, it's a really dynamic movement. There's a lot of motion going on of the structures. So if any of these sites show inflammation, patients tend to see a lot of pain from that. So when we're looking at the cartilage first, that's the shiny, smooth coating that coats the end of the femur bone. When that wears away, that's what arthritis is, and we'll talk about that in a bit. On the inside and the outside of the knee, we'll see the medial and the lateral meniscus. Those help to provide cushion and shock absorption for the knee during range of motion. Those are common pain generators that we'll see in the knee. Then there's 4 ligaments in the knee. So there's the MCL, which is on the right side of the screen and actually not shown in this diagram. The LCL would be on the left side, and those help keep your knee stable. In the center of the knee, the infamous ACL lives right there, and then the PCL is in the back. Generally, these injuries are not subtle. They tend to come with larger forces, larger traumas, and then there's a lot of swelling and pain. So a lot of times patients make their way into our office or the emergency room after those injuries. We'll start with the cartilage because this is one of the more common pain generators in the knee. If you look at this as a normal knee x-ray, this is how a lot of our orthopedic visits start. And one of the main reasons that we get an x-ray is so that we can look specifically at the cartilage. We get this in a weight-bearing fashion so that we can look at the compressed cartilage and judge the thickness, because that's a surrogate for the health of the knee. So if you look here, these are normal joint spaces, and this is in comparison to a patient who has arthritic change. If you look at the inside and the outside of the knee here, you can start to see joint space narrowing, and that's the definition of arthritis. That's what it is. So what do we do when patients have arthritis? They tend to have stiffness, pain related with activity, and pain along the joint line. The first thing that we always start with is the simple thing. So rest certainly works, and activity modification, avoiding high impact activity can be beneficial for patients with arthritis and help modify symptoms. Ice is useful. Anti-inflammatory medication, so Motrin, Aleve, Advil, ibuprofen, those are the NSAID class. Those tend to work well. A cane is very helpful for severe symptoms. Obviously not a great tool when you're on the golf course, though. I put a plus minus in front of physical therapy because patients with severe arthritis will oftentimes have increased pain with increased activity. So there is certainly a phenomenon where as patients do more with physical therapy, it's possible to stir up more symptoms. Not always helpful. And this falls in the same category. There's no perfect knee brace in order to open up the joint space, but often we try them in an effort to relieve symptoms. Injections would be kind of next if all these things fail. There's two main forms of injection. Cortisone is the gold standard. That one is a steroid injection. That's the tried and true. Viscosupplementation or gel shots are also very popular. So that is high hyaluronic acid. It's actually a naturally produced substance by the knee. We noticed that with age and with arthritis, high hyaluronic acid started to decline. So we replenished it thinking that arthritis was going to get cured. Unfortunately, it doesn't cure arthritis, but a lot of people in those early trials had good pain relief. So we've kept it up as a therapeutic tool. Nerve ablation can also be considered. This is good for patients who are trying everything they possibly can to avoid surgery. It's also good in settings where surgery is not appropriate because of other medical conditions. And ultimately, a knee replacement, and we'll talk about that briefly in a moment, but the knee replacement is the final treatment. It is the cure for arthritis here. We get a lot of patients asking about other trends in medicine and physical therapy that they see. A lot of these are heavily marketed. They're not firmly supported in the literature. These would include red light treatment, dry needling, supplements, which include glucosamine, chondroitin, oral hyaluronic acid, collagen, peptides fall into that category. Stem cells, radiation therapy is actually being tried now, shockwave, ultrasound, and e-stimulation. Unfortunately, none of these have been clinically proven to always help patients with arthritis. Obviously, there's a difference in risk profile. If you look at something like dry needling, I will often use that in some of my patients for various reasons. It's a very safe thing to do, as are the nutritional supplements. Something like radiation therapy obviously carries harm. So, we have to think carefully about using these unsupported treatment options, but we often get asked by our patients. So happy to talk more about them if people have questions. This is what total knee replacement looks like. So we're replacing the ends of the femur bone and the tibia with metal. And then what you can't see on there is the spacing in between, which is recreated by plastic. We're going to shift gears here a little bit and talk about meniscus tears, which falls into my specialty of sports medicine. We divide meniscus tears into two different types. One is acute and one is chronic. Patients will develop symptoms and pain at the joint line of the knee, mechanical symptoms such as clicking, locking, popping, and catching, and rotational movements tend to generate a lot of discomfort. We try and recreate some of those on physical examination to help us with the diagnosis. So we'll look at the joint line. If you look at that green hand there on the left, that's at the patient's joint line. We see if there's tenderness or palpation. With rotational stress, moving the tibia back and forth, we can oftentimes identify painful meniscus tears. And then pain with deflection is another tool. Ultimately, if we're suspicious, we'll get an MRI for further evaluation. This shows one of my patient's knee, it shows a patient's knee. And it's a cross-sectional view. So what you're looking at is on the left side here, that's the front of the knee. On the right side, that's the back of the knee. And in the front, since the meniscus is a C shape, you can catch the anterior part of the meniscus. You can see it has a normal dark black triangular shape. That's what a normal meniscus should look like. And in the back here, you can see a posterior meniscus, which has a tear in it. So that white streak through the triangular meniscus, that's indicative of a meniscus tear. That's why we use MRIs to diagnose these conditions. You can also see they have an associated Baker's cyst, which we'll often see next to a meniscus tear, which is fluid that leaks through the tear to cause some knee swelling. And not all tears are the same. There's lots of different patterns, lots of different shapes and sizes, and we get worried about some, and others are less concerning. So the least concerning is that free edge fraying. A lot of patients over the age of 30 have that. That's very common and doesn't require intervention. The most concerning of which is the bottom part of the screen, the bucket handle tear. These ones tend to block knee range of motion, and unless they're addressed, knee range of motion can be lost. These are the only ones we were addressing during the COVID pandemic when elective surgery was shut down, because these ones misbehave and they don't allow the knee to move properly until we intervene upon them. So we identify meniscus tears. Observing them is very reasonable, especially when they're small tears. Patients can continue with their activity level as long as they can tolerate the sport. When they continue to cause pain, rest, ice, and anti-inflammatory medications are first line. We can try bracing and physical therapy compared to the arthritis treatment is more effective in this realm. And then injection. So we don't use gel injections here, lubricating a meniscus tear often doesn't help. One additional treatment that you can consider, still considered experimental, but it's platelet-rich plasma, which is PRP injections. That's where we take blood from your vein, we spin in a centrifuge to get rid of the red blood cells, and we re-inject it into an area of chronic inflammation. That has powerful anti-inflammatory effects, and it is natural. So there are some concerns with long-term steroid use, so PRP can be appealing in certain scenarios. If all else fails, we talk about surgery. So what does surgery look like? We use 2 small incisions in the front of the knee, each are about 1 centimeter. We can put a camera on one side and then small instruments in the other. And once we identify the meniscus tear that was targeted on the MRI, we can do one of 2 things. So the first is called a partial meniscectomy, which means we take the unstable margins and we trim them in order to create a stable meniscus. So if you look at the before there, a lot of times for patients, I'll use the analogy of a hangnail for a meniscus tear. You actually can't feel your meniscus, so the tear isn't what hurts, it's the instability and the irritation and inflammation it causes. So just like trimming your hangnail can decrease inflammation and swelling in your finger, same goes for the knee. So trimming it out is a very effective way to get patients moving again quickly after a minimally invasive procedure. The alternative is repair. So for repair, we can use small devices that allow us to pass sutures across the meniscus so that we can pull it back together. And just like sewing the edges of your skin together, we can get this to heal. The problem with the meniscus repairs is they do necessitate a shutdown from activity, and we'll talk about the restrictions there in a moment. Just a disclaimer, I will show some surgical photos of my cases throughout the presentation. All of them are arthroscopic photos, so they tend to not be very graphic, but in case anybody's uncomfortable with this, you can look away for these portions where they show the arthroscopic photos, which are shown by these circles. So in the top left here, you can see what a meniscus tear looks like in real life. So when we're in there, that's the camera showing our meniscus tear. We call these vertical tears. These tend to heal quite well. This is the younger patient, so the cartilage around the knee looks pristine. So what we do is we pass sutures across, just like sewing your skin edges together. We have small devices that allow us to pass needles within the knee and then tie them from the outside. And then once we get a nice repair, you can see here at the end on the bottom, that's what a femur looks like without any cartilage loss. That's the tibia. And then that's a repaired meniscus at the end. As I alluded to, the problem with this is it does necessitate a much higher level of restriction. So patients' range of motion is initially restricted. They have to be in a knee brace and they have to unload their weight so that that repair has a chance to heal. In general, our patients who have the partial meniscectomy, they're moving pretty fast after 6 weeks. Most of them have made a full recovery by then. It's a lot slower for the meniscus repair. It's about 6 weeks before they're even off the crutches and the brace, about 3 months before they're getting back to high level activity. It can be 6 months before return to sport. So quite a different rehab protocol for each. Historically, meniscus repairs have been indicated for patients under the age of 20, but we're using later and later indications as our patients are becoming more and more active later in life. The most important thing is that patients don't have arthritis. So these studies show results in patients over the age of 40, and both of these studies show that meniscus repairs were effective at restoring functionality. And on the study on the right, it showed that meniscus repairs were superior in results to the partial meniscectomy. So given the right patient, if they're highly active and the cartilage is maintained, a meniscus repair can be appropriate. So move on here to the hip. So we'll get this video to play here, hopefully, and we'll show the dynamic movement of the hip. In comparison to the knee, the hip is a ball and socket joint. So the knee was a hinge joint. It just has a simple motion. The hip motion is much more spherical. And hopefully show it here in just a minute. All right, well, we'll move on. It shows the range of motion in a spherical nature, which is different than the simple hinge joint of the knee. This is a screenshot from that same animation. So what you're seeing is the cartilage there of the hip of the ball portion. The labrum is a common pain generator, which can cause trouble, especially in golfers. So that labrum is a circumferential ring of tissue that goes around the entire perimeter. And then the hip is a little bit more complicated. So there's a lot of other things that can generate pain, most notably the nerves. So nerves from the lower back travel right by the hip. They also often cause confusing symptoms that can mimic hip pain. So one of our jobs is to make sure that these lumbar nerves, which you can see here listed on the right, aren't the true source of the patient's symptoms, because we never want to be treating hip pain when indeed it's coming from a lumbar nerve origin. So that makes us a little trickier. To make it more complicated, there's a huge sleeve of muscle tissue and lots of different muscles that work in a dynamic fashion all the way around the hip. So careful diagnosis in the hip is as important as anywhere else in the body. For golfers, these are some of the main things that we see, and this will be the focus of the talk. So arthritis, bone spurs around the hip, and then torn labrum. If you look here, now we're kind of used to looking at x-rays. So that gap in between the ball and socket, that's a cartilage gap for a healthy patient. You see the worn cartilage here, you can see loss of the spherical femoral head. There's some flattening and some collapse of the cartilage. So that's what arthritis is. Unfortunately, you'll notice a lot of our treatment options start to become redundant. So these are the same ones that we have for the hip, which are the same ones that we have for the knee. So not a lot of differing treatment here. And then ultimately, if you fail all those treatment options and the pain becomes debilitating, total hip replacement can be considered in that scenario. Shifting gears from the arthritis, so labrum tears, again, a common sports medicine problem. Again, we have acute and chronic types of tears. These generate symptoms such as groin pain, mechanical symptoms, again, locking, popping, clicking, those are what patients will describe, and pain with prolonged sitting. So that's a relatively unique feature of labrum. So that's a pretty specific one that we'll frequently ask about. So if you have pain or prolonged sitting in your groin, we start to worry about your labrum. On physical examination, this mimics the pain with prolonged sitting. So this test is called the fader test, where we bring the knee up to the chest and we rotate it through to see if we can irritate a torn labrum to confirm the diagnosis. Again, using an MRI, we can confirm it. That red arrow shows the meniscus tear there. If you look at the other side of the sphere, this is what a meniscus should look like. It should be firmly attached to the bone of the socket. And on this side, you can see that separation away with the white streak. Again, treatment options, they seem somewhat redundant here. Rest, ice, anti-inflammatories. Physical therapy has been shown to definitively be helpful for patients with labrum tears for the hip and help avoid surgery. You can try injections, and then if all else fails and symptoms are severe, we're talking about surgery. On the left here, this is an arthroscopic image of what a labrum tear looks like in one of my patients. And on the right, these are the repairs that we can perform in order to remove the torn edge and reseal the labrum around the perimeter of the socket. We also have to consider bone spurs. Oftentimes, these are the reason the labrum tears in the first place. So you can have extra bone on the socket and extra bone on the ball. Before proceeding to surgery, my patients get a 3D CT scan, and then we put it through software analysis that looks at range of motion digitally, so it helps us determine where the pinch points are. Debriding the bone during the surgery and creating smooth margins is really important to getting a good outcome. We used to kind of eyeball this and look at the amount of bone to take away and move the hip during surgery, but this allows us to be much more accurate, remove the appropriate amount for each patient. On the right here, you can see what we call mechanical burr that allows us to shave away the bone on the socket side. So this is the extra bump of bone. And then after we're done, we're able to create a smooth margin using the 3D image as our guide for the resection. This is on the other side of the hip, on the ball side. The same analysis, we can shoot x-rays in the OR that show us the extra bone that causes pinching of the labrum with certain motion. This is what it looks like with the camera inside the hip joint. And again, our burr allows us to recontour that bone so that there's a nice smooth margin, so that after we perform the labrum repair, it's unlikely to pinch again. It's unlikely to re-tear. That process is called femoral acetabular impingement. We have to address that at the same time as the labrum tear. This is how we achieve the repair. So this device is placing a small anchor in the bone. It's a little over 2 millimeters in size and made of all suture. It balls up on the other side, kind of like a drywall anchor, and it leaves sutures behind. We can pass those sutures circumferentially around the labrum with specialized instruments. And once it's tied around the labrum, we can tie a knot in order to secure it back to the bone. After about 6 weeks, that's healed nicely. We can progress patients off the restricted phase, which are, again, brace and crutches. It takes about 6 weeks, and then 3 months, we rehab back to normal daily activities, about 4 to 6 months to get back to sport, depending on the particular activity. There's been research that's been done specifically on golf compared to a lot of the other studies. I'll show you the return rate after hip arthroscopy is quite high. So the study looked at 95 golfers, and they had a 95% return to golf rate. Interestingly, it was actually a much faster return to golf for professionals compared to us amateurs. So 7.5 months for amateurs, and professionals were able to rehab much faster because they've got pretty big rehab teams behind them. Hopefully we can get this one here to work. There we go. So shoulder, it's also a ball and socket joint, but it's a little different. The socket is much smaller than the ball in this scenario compared to the hip, which allows the shoulder to have much more range of motion. And then it's coated in a very dense muscle sleeve. In this muscle sleeve, these are your rotator cuff muscles. This is what helps achieve the balancing act so that the ball doesn't fall off the socket. I use the golf analogy all the time in clinic. I tell my patients that the shoulder is much more like a golf ball on a golf tee, and it has a lot of inherent instability. That's why it's one of the most common joints to dislocate. So those rotator cuff muscles become very important for stabilizing the shoulder. If we take this screenshot, you can see the cartilage again, smooth, shiny, gliding surface. When that wears away, that's what arthritis is. In the shoulder, we also have a labrum. It's a little bit different than the hip, and it's actually much more important for keeping the shoulder stable. This is the AC joint, another common pain generator. It's called the acromioclavicular joint, and that's the connection between your clavicle or your shoulder blade and or your clavicle or your collarbone and your shoulder blade. So the connection between the two, there's a small joint there that doesn't have much motion. The rotator cuffs, so they're muscles that attach to your scapula or shoulder blade, and then they transition into tendons and they wrap all the way around the head in kind of a circumferential pattern. And there's 4 main rotator cuff muscles that can be culprits. It's very common in golf. In the front of the shoulder, down the front, there's a biceps tendon, and we'll show anatomic references and talk about that a little bit more in a moment. Again, you're kind of recognizing a theme by this point. We want to identify our rotator cuff problems between acute and chronic. Patients with rotator cuff pain, they tend to report pain with overhead motions. They'll report a pinching type pain behind the back, specifically with reaching into to coat, to put on a shirt, get dressed. Those types of movements hurt. Night pain is fairly unique for the shoulder. Compared to the hip and the knee, those tend to not cause patients pain when they're non-weight bearing at night, but the shoulder often causes sleep disruption and can wake people up in the middle of the night with pain. So that's a unique feature. Weakness is also concerning for rotator cuff tears. Location isn't particularly important because it's a circumferential sleeve. Some patients have pain in the front, some have pain in the side, some have pain in the back, and that doesn't help us too much with making the diagnosis. There's a lot of different testing that we do for the shoulder. We're looking at both range of motion and strength. So we take the patient's history into account. This is showing a strength assessment specifically for one of your rotator cuff muscles, your supraspinatus tendon, and we repeat these tests in various positions to determine if we're worried about a full thickness rotator cuff tear. And then we obtain MRIs if we are. So this is one of my patients who does demonstrate a full rupture. You see here with the red arrow, that's the retracted tendon away from its attachment point. So it left some of the tendon behind where it belongs, but this is a full thickness tear. As the name implies, full thickness tears are more concerning than partial tears. Partial tears are really common. Patients over the age of 40 who have lived an active life, we see a lot of partial tears, and those are a little bit more amenable to conservative treatment. Again, treatment options, rest, ice, anti-inflammatories, that's always our first line. Physical therapy is critical for the rotator cuff. Even if you have a full thickness tear, sometimes we can strengthen the deltoid enough to get patients functional if we're trying to avoid surgery. For injections, corticosteroids, platelet-rich plasma can be also considered in this scenario. And then if all else fails, particularly if weakness persists, surgery can be considered. So what does surgery look like? This is a kind of a cartoon rendition of a rotator cuff tear. So you can see this tendon is peeled away from the bone, and this raw area represents the area of bone where the tendon should be attached. We call that the footprint for the tendon. What we can do is, again, we can put those sutures in the bone, those leave sutures behind, and we can create various paths of suture repair in order to seal the tendon back down to the bone where it belongs. And then again, it's about 6 weeks of protection while wearing a sling in order to promote healing of the tendon back down to the bone. Again, this is what it looks like in real life. So this is one of my patients who has a smaller tear. In a minute, I'll show you what a larger tear looks like. The head of the humerus is right under here. It's quite as a sphere shape. You can see the exposed bone for the footprint and the torn tendon pulling away from it. What we can do is place anchors in there, which leave sutures behind. These specialized instruments allow us to pass the sutures through the tendon in a minimally invasive fashion, and then we tie it back down so that we can secure the tendon back over the exposed bone right where it belongs. This is what a much larger tear looks like. So this exposed the entire joint. So the entire rotator cuff is pulled away from the ball. And in this setting now you can see the entire joint, which is abnormal. If this rotator cuff were attached, it should be obscuring the view of the entire joint because it would be covering the surface. So you can see the ball socket and the labrum there. So what we do in this scenario, we use a lot more anchors and a lot more suture. So this patient would get 5 anchors for a large repair like this. We're passing each of them sequentially through the tendon, tying them down, and then bringing them across to get compression of this tendon. And then over time, that tendon will re-heal to the bone. These sutures actually stay in place and get incorporated into the scar. If you ever needed to go back in the shoulder after, it actually becomes quite hard to find these because the tendon starts to look more and more normal after time goes by with the repair. So these can look a little zoomed in and chaotic when we're inside the joint, but again, this is what we're looking at. The rotator cuff is held down to the bone properly, and those sutures hold it in place long enough for your body to heal. Like the other repairs that we talked about, it's about 6 weeks in the sling and then extensive rehabilitation. It takes a long time to recover from these. At 3 months, most patients are feeling pretty good. Nobody's back to activity yet. We have to wait till about 5 to 6 months before we're starting to consider getting back to sport. It can really take up to a year before patients achieve a full recovery, unfortunately. I thought these studies were interesting because they were conducted thousands of miles apart and found pretty much the same results. So the one on the left is the United Kingdom. The one on the right is in Korea. On the left, they looked at 47 golfers who underwent a rotator cuff repair, and they found that the return to sport rate, return to golf, was 76% of them were able to achieve their pre-operative performance level or the pre-injury performance levels after a rotator cuff repair. And we compare this to a study from Korea, and they found mirror image results of that study. So 73% of patients are able to return after 1 year. We talked a little bit about the biceps earlier. There's 2 different heads of the biceps. That's why it has the prefix bi. The short head of the biceps is much more robust. It's much stronger. This accounts for most of your bicep strength with elbow flexion. The long head of the biceps is kind of a nuisance of a tendon. It doesn't contribute much to strength, and it frequently becomes inflamed, often causes pain in the front of the shoulder. Patients will feel kind of a clicking and a snapping with rotation. If that becomes inflamed, patients will generally have pain here. Again, we can try all of our conservative treatment tricks. Ultrasound injections tend to work quite well. We have to use ultrasound for this because the area of injection is actually quite small, so we have to guide the needle to the perfect position and bathe the tendon in the steroid or PRP. If all else fails, what we actually do is anchor the tendon to the bone, and then we get rid of the inflamed portion. So generally there'd be tendon up here, and that's the one that gets inflamed. So we anchor it to the bone and we trim away the tendon here. Patients can make a full recovery without strength loss in this scenario, and it does a nice job at relieving symptoms. We'll finish up here with arthritis. So again, we're getting used to this. You guys are becoming experts in evaluating joint arthritis now. So on the left, this is a normal joint space. This is exactly how you want your shoulder to look. And this is one of my patients who was in their 50s and enjoyed powerlifting and was getting less and less able to perform the heavy lifting that he liked because of his worn out joint. So you can see the cartilage joint space wears out, and then a telltale sign for shoulder arthritis is this large bone spur here. We take most people through rest, ice, anti-inflammatories, physical therapy, injections. Shoulder arthritis patients can tolerate quite a bit more arthritic findings just because the
shoulder doesn't see nearly as much force as the lower extremity joints, such as the hip, knee, or ankle, due to the limited weight bearing of the shoulder. So oftentimes patients can develop significant arthritis before they develop severe symptoms. One symptom that is somewhat unique to shoulder arthritis is night pain. Compared to the lower extremity joints, the shoulder is much more likely to generate severe night pain, and that's often the symptom that drives patients into our clinic. So once we get through the conservative treatment options, which we've already discussed, we can discuss operative intervention in the form of a shoulder replacement. What is different than the hip, the knee, and the ankle, there are 2 types of shoulder replacements. So the one shown here on the far right, this is what we call an anatomic total shoulder. This was the option that we chose for my weightlifting patient after he failed conservative treatment options. As you can see, there's a metallic head which is attached to the stem, and that's anchored to the humerus. And then what you can't see here is in between the ball and the socket, we've placed a plastic liner. That's what recreates the joint. The only part of the plastic liner you can see is a small metal indicator to show us over time that it remains in the proper position. So the other type of shoulder replacement, we call this a reverse shoulder replacement, that actually takes the ball and puts it on the ball side and the socket and puts it on the socket side. And the advantage of this approach is this allows us to perform a shoulder replacement in the setting of a complete rotator cuff tear. So with an anatomic that you see there on the right, we need a functioning rotator cuff in order to prevent dislocation of the joint. The good thing about an anatomic total shoulder is the expectation afterwards is full range of motion and a restoration of strength. With the reverse, we can get stability in the setting of a full thickness rotator cuff tear, which is very common in the setting of patients with severe arthritis. But there are some limitations. So patients don't get the same degree of range of motion with forward flexion. About 120 degrees is the expectation after this procedure. So primarily we're selecting patients who already have profound dysfunction and profound stiffness so that we can improve their function. If you look here, these are what these metallic implants look like. So again, on the right, that's the anatomic replacement with the metallic ball. And then you can see that plastic socket there. That's what does not show up radiographically on the x-rays. On the left-hand side there, you can see the reverse. So you can see the reversed implants where the ball is implanted on the socket. Then you can see the plastic socket, which is implanted on the humeral side. So like I said, there are some limitations with regards to range of motion after the reverse. There are some tricks that we use with our modern technique in order to maximize the range of motion afterwards. One of those is the 3D CT scan. So you can see one of my patients here, we do the preoperative evaluation where a 3D CT scan is obtained and we're able to take it through a simulated range of motion to ensure that we have proper component sizing and proper position so that we can allow for maximized range of motion and ensuring the stability of the implant.
This is a paper that looks specifically at shoulder replacements and golf. So it took 10 different studies that were performed and compiled the results. What we can see here is with an anatomic, return to golf rates were really high. So between 90 and 100% of patients were able to return after an average of 5 to 8 months. It was a little bit lower for patients needing the reverse. These patients don't have a normal rotator cuff. Our expectation is that they do return to golf, but patients can have a little bit more difficulty. 50 to 80% were able to return at intervals a little bit sooner than the anatomic, but still around 6 months is where we start to let patients join a golf club in either scenario. So most patients going through shoulder arthroplasty, we can get you back on the golf course, but there is some difference between the two, and ideally an intact rotator cuff would allow you to have an anatomic replacement. So these are my citations. Those are the articles that I use, and then the references for the images. I really appreciate you guys having me tonight. Hopefully this was educational and you understand a little bit more about each of these joints. Happy to turn it over to Karen so we can go through some question and answers for you guys.
All right. Awesome, Dr. Nicolay. Thank you very much. That was very informative. And we had a couple questions and now they just keep coming in. So I'll read them along the lines, and some of these things may be things that you may not have the answers to necessarily. And so you can just say, sorry, I don't know an answer to that one. This one's a little personal. Anne had hip replacement surgery in April. How long should she wait before she plays golf?
Yeah, that one's a difficult one to answer. You know, in general, hip replacements are a pretty uniform surgery, but there is a lot of nuance. So depending on your bone quality, your bone structure, and the type of implant that was used, there is some variability in when we would allow patients to return. You know, the return can be as soon as 3 months, but sometimes surgeons will hold you off the golf course more if there were specific concerns regarding your surgery. So, you know, I don't want to lean too heavily into that answer, just because, you know, there is some nuance involved in these. So hopefully soon for you. The good thing about the hip replacement is compared to the other joints, that does offer the highest satisfaction rate and the highest what we call normal joint score, where after surgery patients have a hard time remembering which hip was replaced because the outcomes are so good. The hip and the knee, we can achieve really good outcomes, but they're not, I'm sorry, the knee and the shoulder, but they're not quite the hip. The hip is a really good surgery, so hopefully it'll be back on the course soon.
Awesome, thank you. All right, will golfer's elbow typically heal by itself, or, sorry, it just jumped around because we keep getting more questions come in, over time, or is PT or other types of intervention typically required?
Golfer's elbow is an interesting one. So in general, golfer's elbow over time will burn out, meaning the inflammation will be there and bothering you on a day-to-day basis. And over time, it will go away on its own, but that can take a very long time, months or years, and it doesn't go away for everybody. So we always try the conservative treatment. The first line treatment and the gold standard is actually the physical therapy exercises, compared to everything that has been shown to reduce the need for injections and reduce the need for surgery. Surgery is very uncommon for golfer's elbow. Every once in a while, a patient isn't responding well to conservative treatment, but if physical therapy doesn't work, oftentimes an injection will take care of it. But I would absolutely start with the therapy exercises. Those have been very proven in the literature to be our most powerful tool to keep you away from invasive measures.
Awesome, thank you. Okay, what if neck pain becomes pain down the shoulder? Do you think it's better to see a neurologist rather than a shoulder arthropod? That was Lois's question.
Yeah, so yeah, of course. That is a big part of all of our lives. So if you specialize in shoulders, we work very closely with our orthopedic spine surgeons because we share a lot of patients. The most important thing is you properly identify which is which, and there's again some nuance involved in which that is. If the shoulder pain is driven from the neck, either a neurologist or a spine specialist are always my recommendation. And a lot of times we'll share patients and we'll both evaluate them and we'll have a discussion as to which joint, either the neck or the shoulder, is the true pain generator. And to make it more confusing, there's certainly patients who have a bit of both. So we share a lot of patients for that reason too. Oftentimes an MRI is helpful. A lot of patients do have some abnormal findings. Again, if you've lived a healthy life and you're over the age of 30 and you're active, a lot of people have partial thickness rotator cuff tears and other shoulder problems. So it's really important to have somebody interpret the MRI. And if you think the pain is coming from your neck, you need to have that evaluation as well, just to make sure we're treating the right problem. The telltale sign for neck pain is if you have pain that radiates past your shoulder, that continues to your elbow, that goes beyond your elbow. That's a really strong indicator that it's coming from a nerve in your neck. There are really no structures that cross the elbow joint, tendons, ligaments, muscles. They're either above or below the elbow. The things that cross from your arm into your forearm are blood vessels and nerves. Blood vessels tend to not cause pain, so the nerves are often the culprit. So if you have pain above and below your elbow, that includes your shoulder. Oftentimes we're looking at the neck first.
That's great. That's a great answer. And I love that you work as a team so that you don't have to just see one person or the other. You all will work together. So that's terrific news for her. Wonderful. All right. Jason says, many golf injuries involve the elbow. The top of his forearm is always sore. Any exercises or treatment you would recommend?
Yeah, so the top of the forearm, so there's in general, if we're talking about the top of the forearm being here, in general, those are our flexor muscles, and the flexor muscles for your wrist originate high up on your elbow. And right on this bony portion of your elbow, that's where golfer's elbow is. Golfer's elbow is flexor tendonitis, so it's irritation and inflammation of those tendons. It's a very common overuse injury. It's not just in golf, we see it in all sorts of different things. If people have a repetitive job or some sort of manual labor where they have to do a repeated movement, we can see it in that scenario too. And again, the first and foremost treatment to try and shorten the duration of your symptoms and get you feeling better faster are the PT exercises. The PT exercises, I always try and coach my patients on the importance of so I can get buy-in. The ones that are important are called eccentric movements. So for wrist flexion, the eccentric movement is slowly moving your wrist up And we're using very small amounts of weights for this. It's somewhere between 1 and 5 pounds, something you can do 20 repetitions of. And what we want to do is we want to go down on a 1 count and then go up very slowly with the weight on a 3 count. And that's the routine coaching that most of our therapists will give. So eccentric strengthening for that forearm pain is your way out. And if you're not making progress, if you feel like you're stagnant, we have a pretty low threshold to offer injections because those tend to work and give good durable symptom results.
Awesome. All right, thank you. Okay, can adjusting your stance to play through chronic pain actually cause new issues elsewhere in your body?
Yeah, that one's a tough one. That definitely falls into the golf mechanics side of things, and that's a pretty deep, dark rabbit hole. In general, if you are guarding a body part and trying to compensate in turn, yeah, so that creates other vulnerabilities. So, you know, if we're thinking about the knee or the hip, if you're trying to shift weight away from an injured body part, that weight has to go somewhere. So if you're shifting weight, you know, away from your left knee, you're putting more torque and more load on your right knee. Just in general, it's the same concept we see with our limping athletes. You know, a lot of our youth athletes, if they have some pain and discomfort, we'll, you know, observe them, and if appropriate, they can play. But once they start limping, we start to be much more strict because that becomes dangerous because they're loading their other joints asymmetrically. So for golf, it's the same phenomenon. It's just, you know, what you had described. It's modifying your stance so that you can avoid a painful area. You know, it's a tool that'll certainly get you off the golf course and allow you to finish. There's lots of people who are performing, who need to get through a tournament, who do some of those modifications. But long term, you want to get the pain under control so that you can return to your normal swing and normal mechanics. If you're like me, you don't have normal mechanics to start, so, you know, shifting it away isn't necessarily a bad thing. You don't have a good home to start with, so maybe moving my mechanics would help out a little bit. But in general, we want to eliminate pain so that you're not loading the other joints.
Great, thank you. That's a great answer. Thank you. All right, you spoke on treatment for golfer's elbow. How about prevention?
Yeah, that's a tough one. So golfer's elbow is an overuse phenomenon. So cross training throughout downtime can be really helpful. So we'll see a lot of it right now in the spring. So if patients are in town, we're not playing a lot in the winter. If you're traveling and you can play elsewhere, that's helpful. But being in the gym, working on forearm strengthening during the off season is helpful so that once you start, you're not seeing an abrupt change. It's really the change that we start to see the problems with. There's certain other scenarios. Actually, newborn mothers frequently will get tennis elbow or golfer's elbow because they're lifting their newborn repetitively. So that's an abrupt change where we see the pain come in. So for golf through the winter, if you can cross train, keep your forearm strong, that'll make a more smooth transition into the beginning of the year. Otherwise, it's just an overuse phenomenon. So most people playing a static level of golf continuously, they don't really run into tendonitis problems. It's once they start to play more, they go on a trip and they play multiple rounds in one day, multiple days in a weekend. That's where we start to see the problem. So being mindful of the quantity and the duration and trying to exercise to try and prepare for that.
Great, thank you. That's great. And like you were saying, exercising all year long to help prevent once that golf season starts, or before you're taking these trips in the middle of the winter or something. So thank you. That's a good suggestion.
Yeah, it's the abrupt changes that we tend to see the most problem with.
Makes sense. Great, thank you. How about this? Does sliding your feet when swinging the golf club help with reducing your hip from having stress? And then it says, AKA the Scotty Scheffler, and I don't know if that's the name of a.
Yeah, no,
I'm a golfer.
That's a tricky one. So if your foot is allowed to move on the grass, there is less torque through your limb. So we actually see that more commonly in other sports. So when patients are playing field sports and they have cleats on, the cleats have more grab, and when they do, we actually see more rotational knee injuries. So ACLs and meniscus injuries, whereas, you know, if it's wet and slippery, we see all sorts of other injuries. But rotational injuries, if it's wet out, it tends to be hard to get enough torque through your knee in order to have the injuries. Same problem with like early AstroTurf. There was too much catch on patients' knees, and it created a lot of torque. So I suppose you could kind of extrapolate that same thought process to hip movement. If there's a tremendous amount of pull and you're forcefully dragging your leg, your adductor muscles are really getting involved, and you can have adductor tendonitis, adductor strains. But in general, I like the idea if your foot's not planted, there's probably less rotational force through your hip specifically.
Okay, great. Thank you. All right. Barbara asks, do you have a good stretching routine to prevent injury? But she doesn't say to prevent injury where. So maybe I'll just ask, what are your thoughts on stretching to help prevent injury?
That one's a really good question. There's actually been some studies that have looked at that, and the results are surprisingly mixed. Seems very intuitive that more stretching is always better. Some of the studies showed that if you don't stretch a lot and you start stretching aggressively before an activity, that may not necessarily be beneficial. So it's like most things, you want to gradually work your way into it. If you don't have a good stretching regimen, you don't want to be extraordinarily aggressive and do a lot of stretching. You want to use that as consistent. More limber, slow with time, use a consistent basis for stretching before a stretching person around, and there's the stuff, and you constant time to warm up. We see injuries in that scenario as well. In general, warm-ups are always a good idea, getting your heart rate up. The reason that helps is it gets more blood flow to the muscles, so that when the muscles are seeing high degrees of force, they're prepared for it. If you're not warm, your muscles don't have all the blood flow they need, and if you have a lot of torque, a lot of force, a lot of strength through those muscles, we see more injuries. So stretching is a little bit tricky for everybody, particularly with the hip, just because people's individual patients' anatomy is quite different. So there are some people who just have built-in hip impingement where they're not able to achieve the same range of motion. So you got to be careful with stretching. Make sure that you're not stretching to the point of pain, and then develop a routine that's normal for you. So we want to make sure your hamstrings are stretched. We want to make sure your quads are stretched. Those are the biggest muscle groups in your leg that can be predisposed to injury. Your calf is another important one. So getting a good calf stretch in before you play, and then your back. So with golf, the rotational force through your back is tremendous. Pick any of your favorite golfers. There's plenty of back injuries in our pros. So making sure that beforehand you're doing rotational movements before you're tee off on the first hole. All those things help to get blood flow moving, get your heart rate up before you put yourself at injury risk.
Great, thank you. And you mentioned back, and Ron said, and he said, how about talking about back issues? But that's obviously a giant topic. And you specialize in shoulder, hip, knee. But with regard to the back, so some rotation of the back helps to prepare for a golf game. And so I'm guessing people have back injuries from golf all the time. Do you refer them to somebody else? Do you typically see those patients?
Oh, I do see them. A lot of us, when we're evaluating patients, we see, cross specialty patients all the time. And what we generally do is we initiate that first line of treatment, which in this scenario is generally prescription anti-inflammatories and physical therapy. And we get you started down that route. If there's signs that isn't working, or there's warning signs on the exam, then we get you to see a specialist right away. But I manage plenty of people with back pain, and that comes inherent with treating hip pain too. In general, for your back, the common culprits for back pain on the golf course, so you can have a lumbar strain. So you've got what are called paraspinal muscles. They run the full length of your back, connect your head all the way down to your pelvis. With rotational forceful movements, you can have a strain that feels like debilitating because the muscles are quite tense and it's hard to continue to play. The other one is a disc herniation. So with rapid rotational movements, discs can herniate, and the problem with disc herniations is they push on nerves. So depending on which nerve they push on, they can cause all sorts of different symptoms, but in general, it's pain that radiates down the leg. Often referred to as sciatica, but it can be the front of the leg too. Sciatica, we tend to refer to radiating pain down the back. The pain, it can be quite severe, so we help patients along, again, in the beginning with prescription anti-inflammatories and physical therapy. The things to look out for are weakness in the legs. So if patients have weakness in their quadriceps or the hamstrings, they tend to notice that. It affects walking. But weakness in the foot or ankle in particular, so difficulty lifting your foot or lifting your toes, if that's happening at the same time as your back pain, we get a little more concerned. We get an MRI and we look for a disc herniation that's causing compression on the nerve to the point where it's affecting your strength. And in those scenarios, oftentimes we're doing injections. The injection is to calm the nerve down, to decrease the swelling. You know, in scenarios where that doesn't work, we do move on to smaller back procedures, but we try and avoid those obviously when we can. So, you know, radiating pain, seizing pain, cramping pain in the back, those are all common. But as soon as it starts to involve weakness, that's where we get much more concerned to recommend you seek evaluation.
Gotcha. Okay, super. Thank you. That's very helpful. Great. Do you have any suggested warm-ups for golfers with arthritic knees?
Yeah, that one's a hard one. For arthritis, there's a phenomenon called get up and go pain, which indicates that if you've been in one position for a while, it happens all the time with sleep. If you've been in one position for a while, the joint starts to get stiffer and stiffer, potentially without you noticing. And those first couple steps when you get up and move around can be quite difficult. In general, people with arthritis fare a little bit better on even ground. So getting into bunkers can be quite hard. Getting up and around, you know, hazards around the green can be difficult. You know, the obvious one is if you're somebody who enjoys walking, using a golf cart can help dramatically reduce the number of steps during your round and dramatically reduce the force that's being transferred through your knee. So I think the two things are trying to maintain even ground. You got to obviously be quite a skilled golfer to keep your golf ball on even ground the whole time, something I can't do. And then using a golf cart. As far as warm-ups, again, we don't want you to come right off a long car ride, get right out and walk out to the tee box. Some early movement, getting out to the range beforehand, working on stretching, so extending your knee fully, flexing your knee fully, and holding those positions. Those will help get your joints ready for the round.
Great, thank you. Thank you, that's super. Okay, if you have some hip arthritis, is it better to use heat or ice after a round of golf?
Yeah, after we like ice. You know, in general, for a lot of athletic training, we're using heat beforehand and then ice afterwards. That's not to say that heat afterwards is dangerous. There's plenty of patients that find relief after. The common one is if, you know, it's a colder day, you got some back pain, a lot of patients will turn the seat heater in their car on the way home and say it feels good, or a warm shower at the end feels good. So those things aren't dangerous, but you know, what we think about is beforehand we want to warm up. So when patients are getting ready for, you know, any athletic event, if they have an athletic trainer, trainers are getting heating pads ready, getting them on their achy joints so that they can get ready for the game. And then afterwards, if any concerns are there, athletic trainers are throwing ice packs on everything. So ice packs help reduce the inflammation that would otherwise build throughout the round. So always a good idea if you notice an unusual discomfort and an unusual pain during the round, even if you're able to finish, kind of good idea in a preventative way to use ice afterwards to try and blunt any inflammatory response that might come about. The same thing is for non-steroidal anti-inflammatories. Now, you know, I hesitate to give a global recommendation because there's certainly patients that can't use those. They do affect your kidneys, they can cause stomach ulcers, and they counteract with a lot of different medications. Blood thinners are one. But if you do notice pain during a round and you are able to tolerate those medications, you can use them a lot like an antibiotic. So if you start them early and take them with some frequency and some regularity, you can get your symptoms to calm down. That's in comparison to like Tylenol. Tylenol is a painkiller, so it doesn't do anything to actually help prevent the process. The anti-inflammatories like Motrin, Aleve, or Advil, we have some prescription varieties as well. Those ones actually stop the process from building and becoming a snowball.
Got it. Great. Thank you. And you just led right into the next question. With regard to the NSAIDs, if someone has an NSAID allergy or can't take NSAIDs, is there another recommended pain management? And I think she's talking drug therapy for people who can't take NSAIDs.
Yeah, that's a hard one. You know, when you can't take NSAIDs, we rely pretty heavily on Tylenol. Another good alternative would be the lidocaine pain patches. Those used to be prescription only. They're over the counter. They have been for a while. So those are a useful tool too. Both of those would be safe for most patients in a NSAID allergy scenario. And then if you're in a situation where the pain is substantial and you're looking for, a way out, if the pain is becoming more like an injury and you're having a hard time, steroid dose packs can be very useful. So NSAIDs stand for non-steroidal anti-inflammatory medication. The other arm of that treatment is steroidal anti-inflammatory medication. So dose packs are a very common medication that's very safe. It's only 6 days worth of medication, so we're not going to be prescribing that for you before every golf round. But if you've got a flare up of pain, if it's a new thing for you, we can use that as kind of a blanket anti-inflammatory to try and put the fire out before it builds.
Oh, that's great. And we just beeped at 8 o'clock. And I'd like to not keep you doctors late. So thank you very much, Dr. Nicolay. We appreciate the time that you put into this, and the extra time that you gave us for questions, that you left for questions. It was fabulous. I learned a lot, and I'm sure everybody else online did too. Thank you, everyone, for joining us tonight, and thank you, Dr. Richard Nicolay. His information's on the screen if you want to reach out to him and have personal questions. We'd love to have you reach out. Thank you so much, Dr. Nicolay.
Wonderful. Thanks for having me. I really appreciate it.